Okay, it's time to start. Good morning, everybody. Welcome for International Trauma Rounds. This year 13 of this meeting, and I'm glad to have all you together here, people from many continents in the globe. I'd like to ask Maya to introduce the panelists today, and she's going to moderate the meeting, and we're going to have many of you participating, give you your opinion and answers of the management. Ilya, thank you for presenting today. Maya?
Thank you so much. We have two interesting cases we want to share with you guys today. And to present them, we have Sara Matsumoto, who's one of our senior residents, about to apply into trauma surgery as a fellowship. So very excited for her. And also we have Christina Sharon, who is one of our current trauma and surgical critical care fellows, to present the second case. Thank you all for joining.
Yeah, case from Westchester Medical Center, Westchester, New York. Thank you for presenting, Ilya. Today. Go ahead, please. Yeah.
Hello, can you hear me?
Yep.
All right. Yep, my name is Sarah. I'm one of the residents at Westchester. I'm going to be presenting the first case, a case of delayed neck trauma. Oh, no, it's not moving. Oh. All right. So our objectives today are to discuss the relevant anatomy, discuss techniques for operative management, and evaluate injury mechanism, associated injuries, and risk factors. This is a 34-year-old male who presented to us status post a gunshot wound to his posterior neck, which came out through his mouth. He initially presented to an outside hospital, and then he was transferred to us 12 hours after his initial trauma. When he got to the other hospital, he was GCS 4, 3T when he arrived in Westchester. He came intubated. His airway was confirmed with end-tidal CO2. He had bilateral breath sounds. He was clinically stable. On exam, he was notable for swelling in the right side of his neck. So on CT scan of his head, he was noted to have a right MCA occlusion with ischemic changes. Oops. As well as a near complete right common carotid artery transection with active extravasation, as well as a right vertebral dissection with reconstitution and a C3 through 5 fracture. See here, here is the extravasation from the carotid artery. Thoughts about next step?
Maya, would you mind helping us to go around the room and see what people think?
Yes. Sorry, I was just having some trouble with my connection. Yes. Sure. Thank you, Dr. Sharon. Dr. Supa, would you want to make your comments first?
Yes. In this case, I think the patient needs surgery at the neck to repair the right common carotid transection with bleeding. So you can try to do the end-to-end anastomosis or put in the graft. And for the intracranial lesion, usually we let the IR deal with the thrombosis in the brain. In this case, I think we should just repair the injury at the neck, and then the vertebral and the intracerebral vessel, which are more difficult to deal with surgically. We can ask our IR colleague to fix those two pathologies later. Thank you.
Thank you, Dr. Supa. Dr. Hodgman, do you have any comments?
Yeah, it's kind of a little bit difficult to make more comments because I don't have all the images. There was a mention about the vertebral artery dissection. I don't know if it's occluded. The carotid appears to reconstitute after the area of injury. So you need, I really need to have more information to make a plan. Having said all of this, if we were trying to repair the carotid, yeah, I agree with Dr. Supa, endovascular approach would be probably the best approach because this appears to be very high. You can see part of the mandible, so it's probably very close to the angle of the mandibles, which is sometimes difficult to get distal control. So unless I can be sure that I can get distal control, I will try not to explore this. This is zone 3, it appears to be. The other problem with the repair, and this is what we need to consult neurosurgery, is that this patient has been ischemic, the brain has been ischemic for 12 hours already. So a repair with increased pressure into the vessel carries the risk of a hemorrhagic conversion. So again, without more information, is you can see the carotid is totally reconstitute, going above there. Maybe I will try the reconstruction, but it might be a case that the only viable option is to ligate the carotid because the chances of a hemorrhagic conversion will preclude the treatment. But without knowing what's going on with the vertebral artery and the rest of the cerebral circulation, is difficult to make a final recommendation. Thank you.
Thank you, Dr. Hodgman. Dr. Antl, would you like to make a comment?
Yes. So very sad case. So it's more than 12 hours after the injury. There's ischemic injury to the right cerebral hemisphere with poor perfusion of that hemisphere. And that's plus likely quadriplegia, the C3 to 5 level. So I think very poor prognosis. And if he survives, very difficult period for rehabilitation. But normally, in a young person, a transection or a lesion of the common carotid, I agree with Dr. Hockman, you can just ligate that because there should be adequate collateral circulation through the external carotid from the other side to the across to the right side, and then the internal carotid should get perfused normally through that collateral circulation, even with a ligation of the common carotid. So that would be the quickest way to deal with it. If it's in the common carotid, so it's below the bifurcation at the level that you would normally expose when you do the carotid endarterectomy. So with an expanding hematoma, active extravasation, I think it's reasonable to operate to evacuate the hematoma. I suppose the interventionalist can put a stent in, but in this case, probably I would opt for the open procedure simply to evacuate the hematoma and get control. And as far as the intracerebral circulation, I don't know that anything that could be done would make a difference in the prognosis, but I would certainly talk to the interventionalist, although I don't know what they would do for that.
Thank you, Dr. Andrade. Dr. Alex, would you like to make any comment?
Good morning, everyone. I think I had last year probably a case where there was a complete transection and I ended up, ligating both the internal carotid because there's no flow distally. If I use these images as surrogate of, back bleeding, if I'm looking at whatever the cut that's presented over there, there's still flow distally. So I think I would probably reach out to have an endovascular approach to this carotid and probably not tie it off. Just because there is flow distally and I don't think this will transform into hemorrhagic, but that would be, these are my first thoughts on that. I guess depends on the different classification for the vertebral artery. You would have to decide if that needs to be intervened upon or just treated with antiplatelet medication. The thing here is he's probably an Asia A from the vertebral injury, so you don't know his I guess his deficit is most likely from the spinal cord injury, and you don't know how much is from the basically lack of flow in the the carotid artery on the brain with the ischemic changes. But I think he will need to go to the operating room at some point or have a tracheostomy placed, perhaps down the road. And I know some places may even consider for this high-level injury diaphragmatic pacer placement to help with his diaphragm and ventilator issues and pneumonias. But and then based on the trajectory, I don't know how much you need to worry here about the esophagus. There's not much air in this representative cut, but that's something to keep in mind too. Thank you.
Thank you, Dr. Alex. Dr. Rodriguez, would you like to make any comments? Dr. Rodriguez, can you hear me?
Yeah,
Would you like to make any comments?
Yeah, I missed part of the presentation, but I'm going to agree a little bit with everybody or you. Everybody has done in statements which are correct. I want to just to add two more statements. Number one, be nice if you can see the whole angiogram. You know, this is just part of the angiogram. And remind the residents that it's my understanding that the circular Willis, 30% of people don't have a complete circular Willis. So this is very careful when we have mentioned that ligation blindly, you can end it that there is no other carotid on the other side or no circular Willis, and the patient, you give no chance to the patient. And number two statement is, I would like to hear the audience, seems one of the doctor and the green jacket. I'm sorry, I didn't catch your name. The repair of the vertebral artery, I haven't seen anybody repairing. I mean, the vertebral artery enter the vertebral canal at the level of I think it's no C7, C6. And so God make a necessary hole in the transverse process of the C7 because it doesn't enter C6 and go up. It's a very tiny canal. So it's very hard to repair. And I never repair one. I haven't seen in 30, 40 years in shock trauma anybody repair it with fantastic vascular surgeons. So the other treatment is what he mentioned, if you cannot repair it, you use endovascular or just clot the artery. But very important to remember the circular Willis is not complete in many people. That's all my addition to all the statements who are correct, obviously.
Thank you, Dr. Rodriguez. Thank you to the panelists for the comment. Back to you, Dr. Sharon, for continuing the presentation.
All right, so we elected to take the patient to the operating room and did a exploration of the right neck, obtained proximal and distal control, and found a near complete transection near the carotid bifurcation. A shunt was placed and we harvested the greater saphenous vein. And then did a reverse saphenous vein graft from the common carotid to the internal carotid. So you can see here in this picture. Next step from here, any concerns for reperfusion?
Dr. Hodgman, would you like to make more comments first?
No, I have the same concerns that I had before. This is a reperfusion 12 hours later. So the risk of hemorrhagic conversion is very high. I would have seen if it was backflow during the surgery. If it was backflow and 12 hours and that massive stroke, I would probably have ligated this. It's a beautiful surgery. I would love to do this, but I'm not sure that this is going to help. Maybe I'm wrong, but I would be very worried about hemorrhagic conversion in this case. Thank you.
Thank you, Dr. Hodgman. Dr. Sufa, do you have any comments today?
I think the repair is a good option in this patient because there are some reports that stating that even in a comatose patient, after you repair the carotid artery, the patient has some neurological recovery. And after this, I think I would consult the neurointervention doctors to deal with the occlusion in the brain and the occlusion and the dissection of the vertebral artery. Thank you.
Thank you, Dr. Silva. Dr. Alex, do you have any comments to add?
As I mentioned earlier, the fact that there was a collateral flow in it, I think it was warranted to attempt taking care of this transection. I guess there was not probably enough landing zone to do anything endovascularly, but it looks like a great repair. Yes, there is concern for reperfusion. I think for something like this, we would just, repeat, get some baseline CAT scan, repeat the head CT. I'm not sure what else much to do for that. Make sure he's not hypertensive. In addition, we'll probably explore and make sure the esophagus is not injured as well. Thank you.
Thank you, Dr. Alex. Dr. Rodriguez, do you have any comments?
Yeah, they keep mentioning about the backflow. I guess it's accurate at one point. You really believe in that? I give it's accurate, and you can try to repair this, because we're all talking about this flood of blood in the ischemic area. The important thing I want just to ask the audience here, not the audience, but the gentleman here, about the books show beautiful pictures how to do the reposition, use the external carotid to replace the internal carotid. I asked the group here. I personally, in 40 years, I did trauma. I mean, I think maybe I have done 2 of those. However, it sounds like everybody, oh yeah, you just transport the external to the internal. I want to get the experience on that in the group. I think there is a vascular surgeon here in the group. He can tell us. I mean, it can be done, but I don't know how often it's used that versus just put a, like they did here, put a vein softeners, I guess. Any volunteers? Nobody. I guess my question is irrelevant. Nobody wants to answer the question. Maybe it couldn't be understood.
Well, I think that nobody does that, Dr. Rodriguez. That's the reason nobody is answering the question.
Yeah, precisely. That's what I'm saying, because but the book always showed that as an option, and the picture is beautiful.
The book has shown many options that were being done in the past, like transposition of the ureter in case of urethral injury, or injury to the ureter, whatever. And I was dreaming about doing that when I was a resident, and they were totally abandoned because the situation is complex enough for us to make it more complex and create more problems. So that's the reason nobody does it.
Thank you, Dr. Rodriguez and Dr. Hodgman. Dr. Armstrong, did you have any comments to make?
Yeah, so it looks like a beautiful operation. I would certainly be concerned about reperfusion. The issue about the back bleeding is that the injury is in the common carotid. So if you ligated the common carotid proximal to the injury and you saw back bleeding, it means it's either coming through the circle of Willis down the internal carotid, then out the injury, or it's coming from the external carotid from the other side, not through the circle of Willis, back bleeding that way. So you don't know in this case whether if that cerebral hemisphere had been perfused across the circle of Willis. I suppose you could check for that by occluding the external carotid on the right and then seeing if you still had the back bleeding. If you did, then that would be a good sign. So you wouldn't have to worry about so much about reperfusion. So, and then the other point I would make is reiterate what I said the last round, that if you, by doing this repair, it seems like you would have had to ligate the external carotid and then do what looks like an end-to-end anastomosis of the common carotid to the internal carotid. That's really equivalent to simply ligating the common carotid proximal and distal to the injury, and then the perfusion of the right internal carotid arteries through the external carotid arteries. So if you could maybe comment on the choice of doing the vein graft versus the simple ligation, why that's preferable, and whether or not you were able to confirm that the back bleeding was through the internal carotid and not the external carotid on the right side. That would be my main concern before proceeding with the reconstruction.
Thank you, Dr. Angel. Back to you, Dr. Sharon, to continue.
Okay, so there was back bleeding from the external carotid. However, the external carotid had been mostly shredded by the trajectory of the bullet, and so it was ligated. And there was a pretty significant defect between the common carotid and the internal carotid that was bridged by the graft. There was some back bleeding from the internal carotid as well. And then to go back to looking for esophageal injury, the patient did have a EGD that confirmed that there was no injury to the esophagus. So an ICP monitor was placed by neurosurgery in the OR. The opening pressure was 50 to 60. As you can see, the patient actually bled from the side that the ICP monitor was placed. This was a CT head done after the placement of the ICP monitor, and then the patient returned to the OR for a right decompressive hemicraniectomy. This CT shows a new ICH from the ICP monitor, as well as loss of gray-white matter differentiation. The repeat CT head afterwards was stable. The patient underwent a trach and peg on hospital day 4. Currently, he's doing well. He's off the ventilator. He's moved to the step-down unit. He has 1 out of 5 motor in his lower extremities, 0 out of 5 in his upper extremities. He, however, does blink and nod his head to commands, and he is pending placement in rehab. So this is just a quick review of the algorithm for penetrating neck injury, whether or not when it violates the platysma. Obviously, if there's hard signs or hemodynamic instability, you should attempt to go to the OR immediately. However, if there is not and there's suspicion for injury, depending on which zone there is, there may be different managements, but however, each one seems to be CTA just to confirm that there's no injury to the vessels, as well as looking and doing EGD bronchoscopy to confirm that there's no injury to the trachea and esophagus as well. So Rutherford does recommend that the treatment for this injury has come from revascularization in the 1950s to ligation in the 1970s, and now recommends revascularization currently. There is no preoperative marker to date other than time greater than 24 hours from the time of injury that predicts that these patients would be unlikely to benefit from revascularization. So early revascularization has consistently demonstrated improvement or stabilization of neurologic symptoms in these patients with dense hemispheric strokes, even in patients who present attended. Thank you.
Anybody have any comments or questions on the first case? Another interesting point was, if you're doing this revascularization, the reverse saphenous vein graft, do you give systemic heparinization? Do you flush with heparin? In our case, our vascular surgeons did give a bolus of systemic heparin, and likely the hemorrhage surrounding the ICP monitor was likely as a result of that, even though it was reversed. But these are also interesting points to consider.
So the bleeding question, so the bleeding was from the ICP monitoring device?
Correct. The bleed on the left side was from the ICP monitor replacement. However, I think his increased intracranial pressure of 50 and 60 was as a result of the swelling from the reperfusion.
So in retrospective, can we discuss this case, how was managed? I mean, there will be any different now we know what happened? Any difference? Anybody will do anything different? Or it's okay what you guys did? I don't know. Anybody has any comment? Because the group, what is the physician who is in charge of the group presentation? Do you have any comment about that?
Sorry, I didn't know if you were asking the audience or asking us. So from our standpoint, we had a long discussion regarding should we ligate or should we revascularize? And again, 12 hours from injury, dense MCA stroke, arrived with essentially a GCS of 3, couldn't really get any more of an exam from him, and a reported GCS of 4 from the other hospital, when he arrived there. So very poor neurological exam, very large stroke, and we had these imaging. And so I thought it was very interesting, all these decision points. And I think even despite his dense stroke, the recommendation from the little literature we have is to revascularize. Although, he's not in the best of shape, he's following commands, he's awake, he's alert, and he's young, and maybe we'll make some meaningful recovery. So I think from our standpoint, the only thing we discuss as a group to do differently is not to systemically heparinize. But besides that, I think we would have done the same thing.
Okay, so what is the literature? Where is coming from? Because the literature can say anything, So do you know who wrote that? Was it prospective randomized studies? And
no, of course not prospective, not multi-center, not randomized. Based on expert opinion and case reports, and the Bible, right? Rutherford's. That's all we have.
Rutherford, the guy who was in the World War II in Vietnam. Yeah, that's interesting. Yeah, a great book. We all had Rutherford, Yeah, but okay. And so, and you didn't mention. Oh, I want to make a comment about trajectory. I keep saying that because I was lucky to have a lecture by the best coroner in the United States, the coroner, the guy who do autopsies, and one of his statement was, bullets don't follow trajectories. He's right about that. So it was mentioned the word according to trajectory, and particularly in the neck, it could hit anything. It doesn't mean necessarily it's going in this direction like we believe. We used to remember, clips and stuff like that to see trajectory, but the bullets don't follow trajectories. And the other question is, the esophagus was injury. What was done? Just a little repair there, was through and through. Not much has been talked about esophagus. I know you're trying to push the vascular part, but how about the esophagus?
He did not have an esophageal injury.
Oh, I misunderstood that. Okay, all right, I'm sorry.
Dr. Shnaydman, I think we can continue with the second case.
Good morning. My name is Christina Sharon. As Dr. Shnaydman said, I'm one of the fellows at Westchester Medical Center. I will be presenting the second case. This was a 60-year-old male. He presented after a motor vehicle collision. GCS was 5 on presentation. He was intubated for airway protection. It was confirmed with end-tidal CO2. He did have bilateral breath sounds. He was hemodynamically stable. The patient was noted to have a change in GCS from a 5 to a 3T. He was also noted to have some neck swelling with ecchymosis and an abdominal seatbelt sign. What are you guys' thoughts on the next steps here?
Thank you, Dr. Sharon. Dr. Intl, would you like to make your comments?
I didn't hear what you said.
Can you hear me?
No, I can't.
Okay, hello, is this better?
Yes.
Okay, perfect, sorry. Yeah, thank you, Dr. Sharon. Dr. Intl, would you like to make your comments first?
Which doctor?
Dr. Unchecked?
Yes, in this case, hemodynamically stable and a CNS injury and possible abdominal injury. So I would do IVs, two IVs, and all the preliminaries, and then proceed to CT, head, chest, and abdomen and pelvis in this case. I'd be very concerned about with the seatbelt sign that he has. He could have a perforation of a viscus and to complicate his CNS injury.
Thank you, Dr. Armstrong. Dr. Rodriguez, would you like to make your comment?
No, I agree. This patient, most people, everybody will do a pan-CT. You know, it's a patient with an MBC with obviously something go wrong in the abdomen, something could be in the chest and the neck was concerning, and a CT angio will show that. In 5 minutes we have an answer. You know?
Thank you, Dr. Rodriguez. Dr. Hodgman, would you like to make any comment?
No, I agree. This patient is hemodynamically stable, needs a full CT scan. I would be concerned, most likely than not, the seat belt, part of the seat belt was in the neck. And what I have seen in the past is intimal tears in the carotid artery caused by the seat belt. This patient have swelling and ecchymosis, which would be more than an intimal tear. So that would I would be suspecting. He's intubated already, so the airway is secure in case he develop a hematoma in the neck, which I also have seen in blunt trauma patients who have an emergency airway because of compressing hematoma for blunt trauma. And as Dr. Untrek said, when you see the seatbelt sign in the abdomen, you have to be concerned about small bowel injury. But that's all I can say so far. Thank you.
Thank you, Dr. Hodgman. Dr. Super, do you have any comments, John?
I agree with a CT scan of this patient. Thank you.
You mean
Thank
a
you,
pan
Dr.
CT scan, right? A pan CT scan, the whole thing, because, all right.
Dr. Alex, would you like to make any comments?
Yeah, just hemodynamically stable, pan scan and CTA at the neck, and I would just take a really good look around the neck and make sure it's not. For me, I got one sold as MVC, and it was the guy was shot before in the neck, and then he crashed the car. So just make sure there's no hiding, penetrating holes somewhere behind the ear, and that's all. Thanks.
Thank you, Dr. Alex. Dr. Sharon, back to you to continue.
So we proceeded with the chest x-ray and then we pan scan. So on the chest x-ray, his lungs look clear, but you can see there is some widening of the mediastinum. On pan scan, so his CT head was negative. He didn't have any fractures on his C-spine, but the CTA did show a right common carotid BCBI. CT chest had a comminuted sternal fracture. He had some rib fractures and a trace pneumothorax. CT abdomen and pelvis did show a right adrenal hemorrhage, grade 2 liver laceration, and a grade 1 splenic lac, a comminuted acetabulum fracture, a left humeral head fracture. And patient was also noted to be weaker on the left side compared to the right and remained hemodynamically stable at this time. Here I have the images of the aortic injury. You can see the dissection here. And then the right common carotid artery dissection was arising from the origin of the common carotid, and the true lumen was severely narrowed, as you can see with the indicating arrow. And this was actually labeled as a grade 2. However, even though it was a grade 2 lesion, you can see on the image how severe the narrowing is. What are you guys' thoughts on the next step?
Thank you, Dr. Sharon. Dr. Alex, would you like to make a comment first?
So for the aortic injury, grade 1, I think antiplatelet would be, and blood pressure control and heart rate. For the injury here in the common carotid, I think there's enough landing zone to treat this with a stent, and I would just look into that. With regards to the other injuries in the abdomen, I think just serial H&Hs and as he would be on antiplatelet medicine after the endovascular procedure or the treatment of the common carotid artery injury. Thank you.
Thank you, Dr. Alex. Dr. Silva, would you like to make a comment?
Aortic injury, I agree with maybe non-operative management. For the carotid artery injury, this patient has a blunt mechanism, and the pathology is thrombosis with some distal flow, if I'm not wrong, seen on the CT. I think he should be placed on antiplatelet or anticoagulant once the bleeding in the other area is cleared. But in this patient, the treatment may be contraindicated because of the bleeding in the abdomen, the injury in the abdomen. So at this point, we should try to address his abdomen. The other concern is he may have a hollow viscous injury that is missed by initial CT. So the treatment of the carotid artery injury at this point is quite limited by associated injury he has. Thank you.
Thank you, Dr. Silva. Dr. Hodgman, would you like to make any comment?
Yeah, again, this is kind of difficult because we are seeing just only 2 images of both injuries, and you need to see several images to be able to build a 3-dimensional map in your brain. So initially, when I saw this image, my first thought was that this was an intramural hematoma, but now I think I see the beginning of the flap at the bottom part. So there is probably the best way to treat this nowadays will be with endovascular approach. If endovascular approach is not an option, this patient can be explored, but he would probably need, based on the location, at least a partial median sternotomy to get really good proximal control. It's a very low injury. I do not know how the aorta is involved, if it's really a dissection or it's an aortic tear. The classical traumatic injury is an aortic tear distal to the left subclavian. The only layer that remains is the adventitia, the media and the intima are transected. In a classical dissection, which are rare in trauma, they're possible, but they're rare, the dissection occurs within the media and can extend different areas. So I do not know if this is if it's a dissection or is this only an intimal tear. The treatment for those 3 different entities is very different. So I'm not sure. I am guessing that this is an intimal tear alone, and if it's an intimal tear, the treatment is aspirin. If it's a dissection, a type A needs emergency surgery. A type B, you can treat it with beta blockers. If it's a tear, you need to do usually an endovascular repair. So that's all the things I have about this. This patient with a seat belt and a significant external injuries, they have a 15% chance of having a significant compression fracture in the thoracic or lumbar spine. I will look for that too, as other things to look for. But that's all I can say with the information I have. I know it's probably a lot of rambling and mumbling and everything, and I apologize. Thank you.
Thank you, Dr. Husband. Dr. Andrade, would you like to make any comments?
Yeah, so if I recall correctly, you mentioned that there's motor weakness on the left side.
Correct.
Okay, so presumably that's from I would assume that it's from the narrowing of the carotid. And so I would, in a 60-year-old, although 60-year-old these days is young, but I would prioritize the treatment of that lesion, worry not so much about the abdomen, the grade 1 spleen and liver lacerations. You know, you could deal with them if they become problematic, and about the potential for a bowel perforation. I would watch that with serial CTs, looking for accumulation of intraperitoneal fluid and or bowel wall thickening as proxies for bowel perforation. So I would really put a lot of emphasis on correcting the carotid lesion, and of all the options, I think probably a stent would be the best to avoid a sternotomy, like Dr. Hockman said, and to keep the intervention as minimal as possible. So that would be my approach in this case.
Thank you, Dr. Andrade. Dr. Rodriguez, would you like to make any comments?
Yeah, a couple of general comments, for the audience. We use shock trauma when I was there for 27 years, 30 years. Most of blunt trauma at the beginning went to shock trauma, but the penetrating trauma went to the emergency room, because penetrating trauma for us was considered a penetrating trauma, but we did blunt trauma. And we saw, and that's not true, because penetrating trauma has implications too, but what I'm trying to make the point is that blunt trauma could be very complicated. It's not just a gunshot go into the belly or stab wound in the belly. This patient has a neck problem here, has a thoracic aorta rupture. I don't care what you call it, grade 1, 2, A, B, C, D. And it has also abdominal injury. So it's a very complex difference between treating penetrating trauma, which is the most common injury in Latin America, the blunt trauma, which is even more common in Europe and obviously in the United States as well. Now, in regard to I'm going to concentrate on the aorta, thoracic aorta. I was lucky to be almost, and we see 10 rupture aortas a year in shock trauma. There were 2 thoracic surgeons, trauma surgeons. I was one of them, so I saw, you calculate, several hundreds. I was involved directly in the repair. And I got to tell you some experience. Look, the experience is that the angiogram at the beginning not necessarily correlate what I found when I was there. The CAT scan angio didn't correspond exactly. So it was very difficult. We have one of the best radiologists in the world in trauma, Mervis, who wrote a book in trauma radiology. And it's very hard to detect it, it's the intima, the subintima, the interintima. When I was there, in the belly and the chest with my proximal distal clamp, was totally what I found. If I follow what the CT told me, I'll probably be wrong many times. Okay. Now, the third point, come this business of classification of the minimal aortic injury. The guy who wrote that, a very nice young thoracic trauma surgeon from shock trauma, and they did a classification and type 1, type 2, type 3. My question is, I believe that's probably I have operated unnecessarily, because in my days, everybody who has in the CAT scan aortic hematoma and aortic deformity contour abnormality, we did surgery. Okay, there was no this division 1, A, B, C. This came about 10 years ago when this young guy who wrote that paper. And my question to the audience is, I haven't followed that part. I don't know how many people has done this follow-up, because when you don't know to operate a patient with a rupture aorta, in first place, I will not be able to sleep very happy with that. Second, I don't know if the follow-up is, how long it has been the follow-up. This patient eventually developed aneurysms or not. The doctor who did the classification can tell us is any studies follow-up of this non-operatives, like we make a joke, it's a minimal aortic injury, like a minimally pregnant, So can you explain to us, please, what is this follow-up of these patients you have? I don't know, I didn't follow this literature. I don't know there exists that, in numbers, I mean. Any comment for the doctors who
Oh, sorry, so it was a grade 1, which is a intimal tear, and the intimal tear was at the insertion of the ligamentum arteriosum. For this, you should just do like antiplatelets and then repeat imaging, and I believe the interval is 3 months.
I understand that, doctor. I understand. But what I'm asking is any big studies on this, that this minimally pregnant, minimal rupture aorta, which I believe is the case. As I said, I operate hundreds, okay? Unnecessary probably. But is any follow-up of this, or this is one paper? You're repeating what you read in literature. Anybody can support, please, there have been studies on that? How many cases have been followed on this way? How many? I don't know. I don't remember seeing that.
Yeah, I mean, all we have is recommendations from our major trauma societies like East and Western Trauma. There's now a vascular trauma database called Prove It, where all the vascular cases are being logged. I think in the future, we'll have more meaningful data.
Yeah, that's very important. Remember that the guidelines is the president of a society tell one of his friends to write something about that, and you collected 20 friends and they review the literature. Doesn't mean that everybody who is in the guidelines know anything what they're talking about, but they review the literature and come out with some statements. I want to tell the residents, when you say the guidelines say that, yeah, the guidelines say many things. All right, but I agree. There is the data collection, and eventually we're going to have better data. So, but I agree that there is rupture aortas who probably don't need to be repaired. I did a mistake because in my time, I have to repair. That was either it was rupture or was no rupture. There was no way for no repair. And they come in endovascular repair, who the people who wrote that usually never did aortas before, but they wrote this endovascular repair, which is very good. I wish in my time there was more endovascular repairs. I didn't have to be at 3 o'clock in the morning with a big hematoma and I put my hand to control and blew out in my face. So that's a different story. But endovascular repair is proven that is a good way to do it. No question about it.
Thank you, Dr. Rodriguez. Back to you, Dr. Sharon, to continue.
Oh, where's my? So as we had all kind of mentioned, impulse control for the aortic injury. He was a poor candidate for anticoagulation given the blunt trauma from the liver and the spleen. So at this point, we were contemplating, do we do an endovascular approach versus open approach because anticoagulation was contraindicated. Because after reviewing the images, from a technical standpoint, the right innominate artery came off at a very steep angle from the ascending aorta. And because of this, there was concern that passing endovascular equipment from the groin up to the right carotid area would cause further tearing and dissection into the innominate artery, subclavian, or even possibly further injure the thoracic aorta. So we opted for a carotid to subclavian bypass with ligation of the distal right common carotid artery. And here are the images. So post-operatively, the patient remained hemodynamically stable with good right upper extremity pulses. He was found to have a left brachial plexus injury later on, in I think 1 or 2 days after, in addition to the humeral fracture. On hospital day 5, he had fixation of his pelvis, and then he was discharged home on aspirin. He was seen in the office 3 months after for follow-up imaging. He had no neurological deficits and had good recovery with physical therapy. And then the grade 1 aortic injury on follow-up imaging was unchanged. And then we showed a patent subclavian to carotid bypass. Here are some of the recommendations or guidelines in regards to which patients are high risk for BCVI. There is really no level 1 evidence recommendation for screening. Level 2, patients that present with any neurological abnormalities that is unexplained by a diagnosed injury should be evaluated for BCVI. Blunt trauma patients presenting with epistaxis from a suspected arterial source after trauma should be evaluated for BCPI. Level 3 evidence, asymptomatic patients with significant blunt head trauma, as defined below, are at significantly increased risk for BCBI, and screening should be considered. So anybody with a GCS less than 8, petrosis bone fracture, diffuse axonal injury, any cervical spine fracture, particularly those in the C1 to C3 area, or those through the foramen transversum, cervical spine fractures with subluxation or rotational component, and then any Fort 2 or 3 facial fractures. So this was a study that actually was done at our institution. It was a 1-year retrospective cohort that pulled data from the trauma database and kind of just looked at, you know, are there other indications that we should be considering for screening for BCBI? And this categorized the patients in 2 groups, were airbags deployed versus no airbag deployment, and then the incidence of BCBI were our primary outcomes. Secondary outcomes was the incidence of BCBI and cervical spine injuries, and the rates of cervical spine injury in patients with airbag deployment alone. The results showed that airbag deployment did have a significantly higher rate of BCBI, but lower rates of cervical spine. So the airbags were actually protective for cervical fractures, but increase your risk for BCBI. And about 0.75% of those patients with no spine fractures had evidence of BCBI. And then on regression analysis, after adjusting for confounding factors, the airbag deployment was significantly associated with development of BCBI, but protective for cervical spine injuries. And it kind of just begs the question to my next point of, you know, screening for BCBI, and should we be broadening either the screening criteria or including CTAs in our PAN scan for blunt trauma. This is another study, again, that is discussing the screening for BCBI. It was a retrospective single center study that looked at all blunt trauma patients who were getting PAN scanned, also received a CTA of the neck. Of course, the results showed higher incidence of BCBI, about 7.6%. Does anybody have any comments on universal screening for BCBI or broadening the criteria for screening?
I have a comment, a historical comment. Some of the oldest of you guys, a historical comment. I remember a time when in one of the AST meetings, a guy from Chicago, some famous guy, trauma guy, presented 200 cases of blunt carotid injuries, you know, and he mentioned that we should do at those times the CTA was not so famous, you know. Remember, CT came from England. The company was owned by the Beatles. That's what it's called. It's called EMI scan, musical scan. That's the history of CT. You know, if when you watch a CT, you didn't know what you're watching. You know, look like the weather map. You know, the radiologist say, "Oh yeah, I can see something here." Well, anyway, the reason I mention this is because it's historical. This doctor already described that patient with similar thing you're saying should have an angiogram. You know, that was in those days they used, how can you do angiogram? Everybody was suspicious of neck injury, but for the same reason. What I'm trying to say is nothing is new under the sun. Many years ago, we already knew that we had to do some sort of screening. The CTA, in those days was angiogram, then came the CTA. So I agree, people with this should have a CTA, the neck.
Does anyone have any other final comments?
I have a comment about the study that you showed, the one at your institution. It's interesting that it's kind of showing a little bit of the opposite, where you don't have C-spine fractures when other studies with C-spine fracture that prompts screening for broad cerebral vascular injury So it's kind of a little bit interesting finding for me.
Yeah,
But
I guess that's the question. You know, a lot of times one of the largest criteria for screening for BCVI is cervical spine injury. But I guess the question I'm asking is, you know, universal screening, meaning no evidence of C-spine injury, no carotid bruit, none of the traditional screening criteria. Should every blunt trauma patient be receiving a CTA because the incidence of BCVI is present without basically cervical injury just from the sheer tearing of the vessels.
And that's exactly what was interesting to us about this case. Not only was there BCVI without C-spine fracture, but it actually required intervention, which we thought was relatively rare. Because, you know, if we screen more, we'll find more, and we may treat more unnecessarily. And the question is, do we really prevent stroke? But I think there are cases like this that really make a good point for universal screening.
Yeah. The question I have, do you have a 3D recon of the CT angio of the neck? Because I think that's key to kind of decide if you have any landing zone for any endovascular or you burn other bridges. But yeah, I think that's important. Do you have that? We had it, yeah, but we don't have it in the presentation, unfortunately. Oh. But you know, this was extensive discussion with our vascular guys about, you know, potentially doing endovascular approach. Their concern was because the true lumen was so narrow, they were very concerned they wouldn't even be able to get into the true lumen or make the dissection worse or even rupture. And because of his blunt injury with the liver laceration and the splenic laceration, which didn't need any intervention, they were worried that even if they got it and they put a stent in, they would probably need to put him on dual antiplatelet. And we were worried that those injuries may get worse. Well, thank you. Thanks for presenting. Definitely great cases, and I learned a lot.
So well, I have a question. What's so at the end, anybody agree that the literature, you say you find somebody who is not agreeable to do universal CTA, whatever. And this is for the young people. The way you became professor in the United States, you write something controversial, there's somebody writing all the perfect controversial, you keep writing about, at the end you're associate professor, then you get full professor. So, you know, but so at the end, the guidelines are very smart. They said a statement. At the end, they said, we think at the end, there should be a consideration of the clinical experience. At the end, the clinician at the end make a decision, I'm going to do my CTA or not. It's important to learning, to know all these classifications and all these you know, guidelines, but you have to be careful, you know, at the end, there is an old person with a lot of experience, you have to listen to that person because he probably have seen more than what that people write in there in those publications. That's my statement.
Dr. Sharon, you can keep going. We have like 3 more slides to get through.
Oh yeah,
and then get everyone's final feedback.
So the next topic we're going to talk about is how do we treat these BCVI. So the current recommendations are, sorry, the grading scale is here, which we kind of discussed. Level 1, there's no level 1 recommendation for treatment. Level 2, if there are no contraindications, grade 1 through 3 injuries should be treated with antithrombotic agents such as aspirin or heparin. Level 3, either heparin or antiplatelet therapy can be used with seemingly equivocal results. If heparin is selected for treatment, the infusion should be started without a bolus. A guideline for activated PTT goals cannot be determined. In patients in whom anticoagulant therapy is chosen, conversion to warfarin titrated based on the PTT to an INR of 2 to 3 for 3 months, and then to 6 months is recommended. Grade 3 injuries for pseudoaneurysms rarely resolve with observation or heparinization. Invasive therapy, whether that be surgery or endovascular, should be considered. And then in patients with early neurological deficits and accessible carotid lesions, operative and interventional repair should be considered to restore the flow. This is just an algorithm. So do you have signs or symptoms of BCVI? If no, then you look at the risk factors. If yes, you proceed forward to a CTA. If the CTA is clear for like a grade 5 injury, you can attempt endovascular treatment. If it's negative, no further workup. And then if you have equivocal findings, then you do a arteriogram. If it's negative, you stop there. If it's positive and you find a grade 5 injury, endovascular repair. If you have anything grade 1 to grade 4, you do antithrombotic therapy, and then repeat CTA in 7 to 10 days. If the injury is healed, discontinue the therapy. If not, consider some type of intervention. And then the recommendation is then again 3 months of antiplatelet and re-imaging. And this is just a discussion of recommendations of antiplatelet versus anticoagulation. You know, with these polytrauma patients, things to consider for anticoagulation is the increased risk of bleeding from other sources. So this is a paper that looked at the comparison of the efficacy between antiplatelets and anticoagulation, mainly heparin. Some of the studies did look at Lovenox, but heparin was preferred because of the shorter half-life. And there was really no difference in prevention for ischemic stroke between antiplatelets and anticoagulation. However, those patients, especially in the trauma population on anticoagulation, had increased of hemorrhage, not conversion of the ischemic stroke to a hemorrhagic stroke. It was hemorrhages from other sources. So the current thought process is, you know, if antiplatelets are not inferior to prevention of ischemic strokes, then that's kind of the preferred treatment, especially in these polytrauma patients, to prevent hemorrhage from other sources. Does anybody have any thoughts on that? I think that was most of what I had.
Thank you, Dr. Sharon. Do any of the panelists, in the interest of time, does any of the panelists have any final comments?
No, I think after this summary of the literature, I don't think we can add too much of value to the presentation. Thank you very much.
Thank you, Dr. Hodgman. Yes, so if there are no other comments, then I think we can wind up for today because we've already passed the time. So thank you, Dr. Shnaydman and the presenters for presenting, and thank you to all the panelists for all your valuable comments.
If you can send the code for the CMEs,
Yes,
please.
yeah, it's already in the chat, and I'll share it now.
Thank you, everybody, for your comments. It was an excellent discussion. I think we all learned a lot.
Thank you.
Thank you.
Thank you.
If anybody has any cases to present, we don't have a presenter for Monday and the weeks after, so please feel free to email me and we can schedule the presentations.
Okay.